study, which will be presented by Dr. Alexander Eggermont, who's the chief of and director of the Gustave Roussy Institute, the National Cancer Institute of France, and he will discuss the use of adjuvant therapy in high-risk melanoma. Lex.
Good morning. I'll be discussing the EORTC 18071 phase 3 trial. It's a double-blind, randomized, placebo-controlled phase 3 trial looking at Ipilimumab versus placebo after complete resection of stage 3 melanoma. That is lymph node positive melanoma, and that stage is at a very high risk for relapse. When you look at the second line, 5-year relapse rates for stage 3A, 3B, and 3C are varying from almost 40% to 90% at 5 years. So this is a patient population at an exceptionally high rate of relapse, risk of relapse. Now, the stage 3A has the lowest relapse rate. Therefore, in this trial, we only took the patients within stage 3A that had a considerable higher relapse rate because of a definition of a minimum requirement for tumor load in a positive sentinel node. You know that the approved drugs in this setting for stage 3 melanoma are interferon. We brought to ASCO this year individual patient data meta-analysis on adjuvant interferon in stage 2B and 3 melanoma. And the hazard ratio for relapse-free survival is 0.86. So that's only a 14% relative risk reduction. And on overall survival, it's 0.91. That represents only a 9% relative risk reduction. This means that although there are approved adjuvant therapies, they are still to be improved, and this is clearly still an unmet need. Ipilimumab was the first drug approved for metastatic melanoma, stage 4 melanoma, based on a proven impact on overall survival. So this trial that I'm going to present to you is the first trial ever with a drug that had an improvement on overall survival in metastatic melanoma. This is the trial design, 475, 476 patients in 2 arms, either receiving Ipilimumab every 3 weeks for 4 injections at 10 milligrams per kg, and thereafter a maintenance treatment schedule for the same dose every 12 weeks, up to 3 years. And the other arm, obviously, the same schedule, but with a placebo. So there's treatment up to a maximum of 3 years. Primary endpoint is recurrence, relapse, free survival, RFS. So this analysis is the final analysis of the primary endpoint, being RFS by independent review committee. Secondary endpoints are overall survival, distant metastasis-free survival, the adverse event profile, and quality of life aspects. We performed the trial in terms of enrollment in 3 years, and here comes the primary endpoint. So the recurrence-free survival, did the trial meet its primary endpoint? And the answer is yes. Let's first look at the table in here. So what does it tell you? It tells you events and number of patients. In Ipilimumab, 234 patients relapsed out of 475 patients treated. In the placebo arm, 60 patients more relapsed out of the 476 patients. So that is not 16, it's not 21, it's not 23, it's 60 patients, which is a robust number of patients. The hazard ratio, therefore, was also met, is 0.75. And this is associated with a significant p-value of 0.0013. We also looked at absolute differences in relapse-free survival rates at 2 years and at 3 years. Those kind of numbers are much simpler to explain to patients. So the difference at 2 years is 8% in absolute terms, and the difference at 3 years is 12%, favoring, of course, the Ipilimumab treatment arm. Then the bullet points above the table. So primary endpoint met, but second bullet point. The risk, so the RFS benefit was seen across all pre-specified groups. So within the trial, there was stratification for stage A, 3A versus 3B versus 3C, but we also pre-specified as groups of interest patients who only had microscopic involvement, so sentinel node positive disease patients versus palpable nodal macroscopic lymph node involved patients. And we also saw the benefit in ulcerated patients with an ulcerated primary melanoma versus a non-ulcerated primary melanoma. A word about safety. So immune-related adverse events are the characteristic of these immune checkpoint blockers because they also have effects on the immune system at large. So in terms of grade 3, 4 events, it says 42%. But here you must make the split between grade 3 events, which are immune-related adverse events that will discontinue treatment. That was 36.5%. And grade 4 immune-related adverse events, which are the really serious ones, that was 5.5%. The dermatologic ones are usually not dose limiting, but the gastrointestinal ones and the endocrine ones are the most important ones. So diarrhea and colitis are, of course, intertwined, and the percentage in grade 3 events is 12, but in grade 4 events is 3. And for the endocrine events in total, we saw grade 3, 4 in 8.5%, but there was only 1.2% for grade 4 events. What is a grade 4 event endocrinopathy? It's a shutdown of the pituitary gland with a shutdown of the adrenal gland that can lead to an acute situation, and that's why it's grade 4, which is called Addison crisis. And then also we see autoimmune hepatitis as one of the immune-related adverse events, which was actually 8.5% out of the 10.6% of events listed here. Now, immediately behind that column, you see, did these events come to resolution? Because there are treatment algorithms how to deal with all these kind of immune-related adverse events. And as you can see, 90%, 94%, and at the bottom, 95% comes to resolution. The only adverse events that may linger on for a very long time are the endocrine adverse events because patients may require hormone replacement therapies for years. Very important point. So what are the conclusions of this study? First of all, it met its primary endpoint, so it clearly has efficacy and is associated with a significant improvement in relapse-free survival given in this trial at this dose of 10 milligrams per kg. The median relapse-free survival showed a benefit of 9 months, 26 months versus 17 months. But I also gave you the absolute improvement of rates at 2 years, at 3 years, which were 8.5% and 12%. Hazard ratio for the primary endpoint, 0.75, with a p-value as listed here, 0.0013. Pre-specified subgroups all showed benefit for treatment. The data, however, remain blinded for overall survival and distant metastasis-free survival and will be reported at future congresses. Why? Because at the follow-up time of 2.7 years, the trial is mature for the primary endpoint and has reached 528 events. but not yet mature for distant metastasis-free and overall survival. The safety profile resembles, is in concordance with what we know in stage 4 metastatic disease, although the endocrinopathies percentage is higher than what we are used to see in stage 4 disease. There's one more trial which is ongoing and still actively accruing. It's ongoing in the United States, the E1609. It's evaluating 2 different doses of ipilimumab, 3 or 10 milligrams versus high-dose interferon. Thank you for your attention.
Thank you, Lex. So I think this is a very important study in framing the concept that we can move checkpoint inhibitors that have survival benefit in metastatic melanoma, this particular one, ipilimumab. And now this is the first randomized large global study to show that it has activity in the adjuvant setting. I want to stress activity, meaning there is a delay in recurrence of melanoma. However, I would argue that that delay is about 10% at 3 years, and it's comparable to a drug that's already on the market, interferon. And there was toxicity with this regimen that was seen at slightly higher levels than when given in the metastatic setting. And there were 5 treatment-related deaths. Now, I think it's critical, obviously, this class of drugs has, in the metastatic setting, has been underwhelming regarding progression-free survival, but much more accentuated effects on overall survival. So I think it's very important we wait and see what the overall survival data from this study, as well as the direct comparison with interferon in the randomized US intergroup study, which has finished accrual recently, before we come to firm conclusions about ipilimumab's role in the adjuvant setting. Remember, we can salvage these patients in the metastatic setting, not just by improving their survival, but by producing long-term survival/cure. And so our tolerance for death or severe toxicity in the adjuvant setting is a different bar than in traditional other type approaches.